is everybody? Oh, the lights just, oh, that was good, Tori. That's perfect timing. So thank you for coming out for the second part of our joint wellness series. Our first one was last month with Dr. Alfonso. Of course, today we have Dr. Boyle here. And there were some little flyers for you to take for the third part, and that's going to be with Dr. Smith, managing some common knee issues. So we do plan to continue to do this into the future, so any feedback is great. So without any other announcements to be made, thank you.
I just wanted to say thanks to the people who put this together. Can everybody hear me? I mumble a little bit in the operating room, so if I fall into that, just let me know. Tori, you can definitely give me a wave if you can't understand what I'm saying.
All right.
It's such a nice space for us to speak in. When I first came here, I didn't talk to Kate Cotter, which was kind of massive and cavernous. This is a very nice size space to fill up. I would highly encourage you guys, two things. I would highly encourage you to check out the next talk, Dr. Andy Smith. I didn't know he was giving the next talk, everybody. But Andy Smith is an outstanding surgeon, very, very well-versed in all of the literature that affects sports medicine in general, but specifically knees. So if you have any issues or concerns or just interest, I would suggest that. And the other thing that we shared is feedback. For us in starting an endeavor where we're doing community talks and increasing our footprint, if you will, in the community, your feedback is very important to us. What can we make better about the talk? Slides, volume. What can we make better about the facility? Anything that you have to share, we would very much appreciate it. So I wanted to thank you all for coming. My name is James Boyle. I am a orthopedic surgeon. A lot of people can wonder sometimes if I'm a podiatrist. I am not. I don't want to be compared to a podiatrist. I don't want to be confused with a podiatrist. No, they do what they do. I do what I do. But an orthopedic foot and ankle surgeon is, as all the people in my practice, somebody who goes through 5 years of residency for general orthopedics. You do everything from pediatrics to spine to foot and ankle to knees to trauma, especially. So you do everything, and then you spend a year doing your subspecialty training. Some people go to sports medicine, some people go to hand surgery, and a small number of us decide that the foot and ankle is interesting enough to go into it. The other people kind of sneer and say, gross feet. We don't want to go there. But I, fell in love with the anatomy and the biomechanics of the foot and ankle when I was, I guess I was a third-year resident in my pediatric rotation, and we did probably about 3 or 4 reconstructions for a disease called Charcot-Marie Tooth disease, which is a nerve disorder. And when you go from seeing a child, 10, 12, 16, who can't walk one day, to be having a foot that's curved in and not being able to put the flat part of their foot, the bottom of the sole of their foot on the ground, what we call plantigrade, to being able to kind of look down and see the tops of their toes and the look on their face and the realization that they're going to be able to walk is it's kind of it's life-changing, and that was what drew me to this, and everything I've done since has kind of made me stay in it, especially in my fellowship. So I will give you a little bit of background about me. This is not my first career. I spent 3 years as a high school English teacher outside of Albany, New York. I'm from upstate New York. I was born about halfway, I was born in Albany, but lived about halfway between Albany and Pittsfield, Massachusetts. A tiny little town called New Lebanon, just in the outskirts of the Berkshires. Taught right outside of Albany, decided that my love was still medicine, so I went back to school. It took me about 3 years to get back to school. I went to medical school at the University of Buffalo. Love that city. A lot of snow, but very warm people. Went on to do my residency at the University of Connecticut in Hartford, not in Storrs. The hospital is in Hartford. Rotated through various hospitals. There are about 5 different hospitals. Decided to go into foot and ankle. Went down to Baltimore for a year to do subspecialty training with a gentleman named Mark Meyerson, who I think probably he's retired at this point, but is certainly considered one of the godfathers, if you will, of East Coast foot and ankle. And he's the reason I went there. I wasn't at Johns Hopkins. That's what everybody asks when you say Baltimore. People think Johns Hopkins. Dr. Meyerson had left Union Memorial Hospital and went to the Catholic Hospital, Sisters of Mercy Hospital down there, because they basically gave him a blank check and he built this amazing facility where we operated like crazy, and it was a great experience. So that's my background. I came here straight from fellowship, started my practice here in 2009. I brought 2.5 kids with me. My wife was about 7 months pregnant when we moved here, and have absolutely loved raising my family here on Cape Cod. I'm going to backtrack for 2 seconds just to introduce some people in the back of the room. When I was in transition from teaching to medicine, I left teaching completely and got a job as a nurse's aide in an emergency room, and spent probably 2.5 years, maybe 2 years, doing nurse's aide work in various areas. And one of them was the emergency department at Albany Medical Center, where I met that gentleman right back there in the blue coat. His name is Jeff Terwilliger, and Jeff actually trained me on how to be a nurse's aide when we first met each other, and that was 22 years ago. And then I went off to medical school. Jeff went off to live in Rochester as a paramedic. He went to PA school. I went to residency, and we were kind of bouncing back and forth between Rochester and Buffalo and Connecticut. Finally, I got here, and about 1.5 years later, I called him and I said, I need a PA. And he kind of laughed and he said, really? And I said, really? And so Jeff and I have known each other forever. He was a PA in the medicine service, and then came to work with me. So I'm the only orthopedic surgeon he's worked with. So the other person I want to introduce you to is Tori Victoria, who is my surgical scheduler, sitting back there. I'm the only foot and ankle surgeon on Cape Cod. I'm the only orthopedic foot and ankle surgeon on Cape Cod. From Provincetown to, probably, I think there might be someone around Plymouth, we said, maybe South Shore. And that means my volume is very big. I mean, I don't know if any of you guys have tried to get in to see a dermatologist on Cape Cod. Right. So, and there's more than one of them. So there's Jeff is an extension of me, and so a lot of times, people call in and they say, I want to see Dr. Boyle, which is fine, but it's usually a longer wait to see me. And I would send anyone in my family, including myself, to see Jeff, who really is truly an extension of me and has an unbelievable clinical skill. So that's a little bit about me. Okay. If you have any questions, regarding my training or anything like that, we can certainly address it at the end. But for now, we'll get into some common foot problems. So just an overview of what we're going to talk today. I wanted to go over some very, kind of general foot and ankle information, a little bit of anatomy, a little bit of statistics on how we use our feet. And then we're going to get into talking about arthritis of the foot, and I probably should have foot and ankle up there. The next topic will be adult-acquired flat foot, which is commonly called, just flat feet. We call it in the business posterior tibial tendon dysfunction, and we'll get into why we call it that. And then the other common, the ever common bunion deformity, hallux valgus, as well as plantar fasciitis, which is another common issue. In the arthritis of the foot, of course, we'll talk, or foot and ankle, we'll talk about treatment options for that also. So basic anatomy, the foot is actually made up of 28 bones, including the fibula and the tibia, which are your shin bones up here. The fibula being the bump on the outside and the tibia being the bump on the inside. And there's about 30 different joints. A good majority of those are the two little joints in your small toes. Not all of them are massively important, but anyone who has hammer toes realizes that those little joints become, quite an issue when they start to cause pain. The balance that you put, or that you require on your foot to come down in a normal position, to hold your weight through your stance phase of your gait, and then to go through the transition into locking, to go through the push-off phase of gait, involves about 100 muscles for balance, both balance and mobility. So it's a really, is another reason why I like foot and ankle, is the biomechanics are kind of stunning of how the foot works between joints relaxing and joints locking for push-off. The easiest way to think about the foot and ankle and it kind of simplifies a lot of what treatment involves actually, is as a tripod. So if you take your fingers and you just put them like this, you've got your big toe, your little toe, and your heel bone. And everything that kind of can go wrong with the foot, all of these disorders that we're going to talk about, have to do with an abnormality of that tripod. Okay, and normally your weight your foot strike here starts at your heel bone and then radiates or follows through, if you will, toward the second toe. If you have a bunion, that tripod is spread out this way, and so you're not loading normally through your second toe. If you have flat foot, you are tilted this way, so you're not loading that normally. And your foot is not what we call plantigrade, or in a normal tripod, kind of distribution of weight. Some general facts about how many people in here use Fitbits? Anybody have a Fitbit to count your steps? Yeah. So, I mean, most people are very, kind of aware of how many steps they're taking per day. They have goals, Apple Watch, all those kind of things are giving us kind of reminders of getting up and moving around, which is great. On average, the Americans take about 5,000 steps per day, and again, that's average. So you got your people that work on their feet all the time. They're moving, they're shaking. Mail carriers. Think of jobs where they're moving all the time, versus desk jockeys who spend most of their time sitting, which is now becoming something that doctors are beginning to kind of rail against. They say now sitting is the new high blood pressure. It's this, they don't want people sitting. And actually, we in the last 2 years converted all of our desks over to convertible desks, so people can sit or they can stand. So it's good for them. But that 5,000 steps per day translates to about 1,825,000 steps a year. Now let's say there's someone out there who's got a Fitbit on and they're doing 10,000 steps a day. Well, that math is pretty easy to do. You're upwards of 700,000 steps per year. So it's a huge amount of force that we put on across our feet every day. Okay, that force is usually about 3 to 4 times our body weight with walking. If we are doing exercise where we're running or we are carrying heavier loads, obviously that's going to go up. So do the math in your head. If you're 200 pounds, you're talking 600 to 800 pounds of force across your foot and ankle joints. These are not large joints. Your hip and your knee, the surface area of contact between the lower joint and the upper joint, we'll call it just to be general, is much larger than that of the ankle. The talus, the end of your shin bone where it meets your ankle bone is kind of like a large postage stamp. It's not that large, and especially in people who have smaller skeletons, which women generally have smaller skeletons than men. About 50% of the population in the United States has some form of arthritis of the foot and ankle. So this is a very ubiquitous issue. Whether it is mild, whether it is severe, whether it is primary, meaning it kind of just developed on its own, or whether it's traumatic, meaning you had a fracture or multiple sprains when you were younger, and that has led to abnormality as you have gotten older. So what is arthritis? And again, this is a very kind of general view of it. It's inflammation of a joint. Arthro means joint in Latin, and itis is the root for swelling or inflammation. We say tendonitis, we say arthritis. There's a bunch of itises. You can have inflammation in multiple areas of the body, and it's one of the leading causes of disability in the United States. And that's not just plain disability; that's just kind of functional disability. Some of the characteristics of arthritis, you notice, this is a good comparison here because this is a relatively normal joint space and this is a relatively normal joint space. And you look at this and this versus this, and that joint space is gone. So when we talk about joint spaces, just for clarification, you look at an X-ray. X-ray is all based on how the beams pass through the tissue. The more dense the tissue, the less the beam is going to pass through. And so when the beam doesn't pass through, a negative image gets produced on the plate. They're all digital now, so we don't really have these plates that they use anymore. But that's exactly how an X-ray works. Oops, sorry about that. But this space here, this space is not empty. That space is cartilage. There's a little bit of cartilage on this bone, and there's a little bit of cartilage on this bone. And those two surfaces meet together with a very small amount of fluid in between the two. And that's where our joints are what we call articulate. They kind of come together and they move. One of the facts that I love it's one of those things that just sticks with you, is that the coefficient of friction, in other words, if I take this phone, and I have to slide it across the table, it takes so much energy for me to overcome the friction between the phone and the table in order to push it across. You can imagine sliding ice on ice. It would just kind of fly, you know, it'd be like one of those, what is it, curling? You know, the broom and everything? Yeah. So, you know, that looks like it doesn't even have any friction. Well, the coefficient of friction of normal human cartilage is 10 times less ice on ice. So it really is perfect tissue. It is the perfect tissue for joints to meet. But when it goes bad, it goes bad. And it goes bad in a good way, in a bad way, rather. And you can see here, this joint versus this joint. Narrowed. The bone here looks kind of grayish. The bone here looks very white. The body is reacting to the arthritis. It's creating more dense bone in response to the increased force across there. Generally, what causes pain with arthritis is the inflammation of the surrounding tissue. Okay? Every joint in our body has a bag of tissue that goes from one bone to the other. It circumferentially goes around the joint, even if it involves, you know, more than 2 bones, which the image on your left shows. That bag of tissue holds fluid which lubricates the joint, which is very important. When the joint gets irritated, the lining on the inside of that bag of tissue, called the synovium, gets very aggravated. It produces more fluid, so we get swollen joints. The more the joints swell, they push on the bag of fluid, there's a lot of nerve endings there, and it hurts. And as you go through your day, following a typical pattern of arthritic pain, which you start out stiff in the morning, you kind of work through it, and then by like 2 o'clock in the afternoon, it's starting to bug you again, and by 5, it's throbbing, you get into bed, and it's hard to fall asleep because it's pounding. That involves that joint getting more swollen as the day goes on. There's different types of arthritis, as I touched on before. There's osteoarthritis, which is essentially cartilage breaking down. We just talked about, causes inflammation in the joint. That happens mostly in adults, although it's never been directly age-related. We refer to this mostly as wear and tear arthritis. It just kind of happens on its own, primary arthritis. You can have rheumatoid arthritis. Now this is a much, much different beast. It's a systemic disease. It is an autoimmune disease where the lining of the joint actually attacks the cartilage and destroys it. And so there's different characteristics of that, which we don't need to go into here. But it may affect the whole body. And I'm sure most of us know somebody who has rheumatoid arthritis, and you can see it change their hands, change the way they walk. Often will change other things in their skin, and sometimes they get rheumatoid nodules or bumps in their soft tissues. Post-traumatic arthritis, which is the most common type of arthritis, certainly in the ankle, and probably, I would say, the majority of arthritis in the foot, develops after a trauma. So you had a fracture that involved the joint line when you were 20, skiing or whatever the case may be, and that fracture leads to an abnormality in the mechanical alignment of the limb, which then goes on to go through those 1,800,000 steps per year. And like a car engine that's just a little bit off in its with one of the pistons or something like that, it's eventually going to wear out. The body essentially is a machine. It's a regenerating machine, which is kind of nice, but it is a machine. So common locations of arthritis in the foot and ankle. Great toe, which the Latin for that is hallux. The midfoot, TMT, stands for tarsal metatarsal joint, and I'll point these out by x-ray in a minute, as well as the subtalar joint complex. The subtalar joint is the joint below your ankle. It's often confused with the ankle because it's so close. It's only separated by about the height of your talus, which is often 1 inch to 2 inches. The subtalar joint complex is what I like to call our sea leg joint, because it helps us to do side-to-side motion. So when you're on a boat, you're kind of hanging on and it's doing this. You're moving through your subtalar joint. Uneven ground. When you go for a walk at the beach, when you go for a walk across a field or something like that, that uneven motion is all being absorbed through your subtalar complex. Very important also with locking and unlocking while we're walking. The ankle joint is more stairs. So straight ahead walking, incline walking, that's when it's going to bother you, and certainly stairs. So a lot of times Jeff or myself will ask, does this bother you more when you're walking up and down stairs or walking on uneven ground? And it's all part of trying to tease out that location. So arthritis of the great toe is called hallux rigidus. Kind of self-explanatory. It's also known as a dorsal bunion. A lot of people confuse this with a bunion. With hallux rigidus, the joint or the bump is going to be on top of the foot. With a bunion, the bump is going to be on the inside of the foot. Okay, and we'll talk again more about bunions a little bit later. There's multiple causes for this, and this, whenever a researcher or a doctor or whomever says, "Oh, there's multiple causes for this," that means we don't really know. It translates to kind of our guessing. It can be micro trauma, meaning something happening, multiple times per day for years and years and years. It can be a single thing trauma. I dropped a wine bottle or a log or something like that on my big toe, and it's never been the same. It actually can result from poorly fitting shoes, which is also the #1 cause of hammer toe deformity. Shoes that are too small for people. It can also be caused by foot deformities other than in the great toe, which cause an abnormal loading of the great toe joint. And again, it causes pain more on top of the big toe and pain with motion in this plane. Okay, so side-to-side motion doesn't really bother people too much, but it's that up and down motion. And I think I have it. If these x-rays are tough to see, I apologize. I can't zoom them in. So this is a normal joint here. Obviously upward motion of this, what we call the phalanx, and downward motion of this metatarsal. This is the joint we're talking about here. This joint is normally pretty well protected from arthritis unless you have some sort of trauma to that joint. As the motion begins to get limited, the joint becomes narrowed, more pressure is put across the joint here, and that results in the body reacting by kind of laying down more bone. Bone spurs, or osteophytes as we refer to them, are very, very common in any arthritic joint. I'm sure there are some people in this room right now who have worked with their hands their whole lives, and you can hold your hand up and your knuckles look, kind of knobby, if you will, if not, large. That's bone spurring, okay? Knees do the same thing, and often your hip will do the same thing, but of course that's buried in all the soft tissue, so we don't see that as much. That bone spurring is very, very easy to see on the top of the foot, and it shows up as a massive lump on top. Dorsum of the body means the kind of like a dorsal fin, the top side, if you will. So we call the top of the foot here the dorsum, and the bottom of the foot the plantar surface. And that's why we call this a dorsal bunion, because it's a bump on top of the foot. X-ray wise, you can see very clearly, like that other X-ray I was pointing out. This is what's known as hallux limitus. It's a kind of a grade of hallux rigidus. It means basically that the X-ray doesn't necessarily show all of the joint narrowing and osteophytosis or bone spurs that the hallux rigidus does, but that there is limited painful motion at the joint. Midfoot arthritis. So we're kind of going from the toes and moving upward toward the ankle. This is the tarsal metatarsal joint right here. This is these are your metatarsal bones. They're synonymous to the bones in the back of your hand, the metacarpals. And then the tarsal bones are these bones right here. They obviously go all the way across. There's 5 metatarsal bones, and there's 4 tarsal bones. The 4th and 5th metatarsals articulate with a single bone on the outside of the foot. Interestingly enough, as we move from the 1st metatarsal out toward the 5th metatarsal, the need for motion increases. So while we can treat arthritis here one way, we have to treat it here another way because of the need for that motion. We can't treat them in the same fashion. So it's the same concept, basically. The joint narrows, you get bone spurring, and you get pain. Pain sets in because of inflammation and breakdown of the cartilage. You can have midfoot arthritis primarily for rheumatoid or post-traumatic. And actually, I just got a consult for a Lisfranc injury, which is an injury where you actually will dissociate this joint, and the metatarsals kind of slide off the tarsal bones. It's a pretty bad injury. And you can see here, it's a little bit tough to see, I apologize, but there is a bone spur on the top of the foot. Some people will come into the office and they'll have pain just from pressure down from their shoes on this bump. They get a little bit of numbness into their big toe because there's a nerve that kind of runs right over the bump right here and then goes down toward this area of the foot. And they can get away with just having the bone spur removed. But you have to be careful about whether or not the arthritis goes all the way down into the joint. These bones are, on average, anywhere from 18, which is small, to kind of 30 or 32 millimeters in height. So that it doesn't seem like you would have bones that tall in your foot, but they're there. And that's why a lot of people also with midfoot arthritis will actually have pain in their arch too. Okay? Second and third joints here, second and third are more common. Am I in your way? So midfoot arthritis, this is obviously a very extreme case, but you can have flat foot go through the midfoot joint as that joint collapses. It makes for very difficult shoe wear with a deformity like that, as well as a large bump on top of the foot. Things like clogs, Dansko clogs, tight shoes, anything with a strap across the top becomes very, very difficult to use. And eventually, if you have flat-footedness like this, and you have this kind of deformity that happens through the midfoot, you can get skin breakdown. I don't see as much of that here as I did in my fellowship, because that was a kind of a referral center. But we have people walk in there, you take down the bandage, and you're staring at their bones, and you're kind of like, where have you been? So severe deformity can result from this, but generally, your primary care doctor, some orthopedic surgeon or somebody is kind of keeping an eye on it before it gets to this level, or should be anyway. So the subtalar joint complex, this is the one, the sea legs, the one that deals with uneven ground. It's made up of 3 joints altogether. You have the talonavicular joint, which is this joint right up in here. Just for reference, these are toes out here, this is your heel bone, and then your shin bones would be coming up from here. So we're looking at the foot from the side. This is the talus, the bone underneath your shin bone that makes up your ankle joint. And the talonavicular joint, the calcaneocuboid joint, and the subtalar joint, or the posterior facet of the subtalar joint, make up that complex. And those 3 joints work in concert to allow your foot that side-to-side motion. It's very important because when you are putting your foot down on the ground during your walking phase, things we don't think about, we just kind of use our feet. When you're striking on your heel, this kind of triumvirate is supple. So it allows for your foot to kind of contour to the ground underneath it, and when you go to push off, it locks so that you have something to push off on. So this is a very, very important complex of joints that, if it goes bad, can make walking even on flat ground, but certainly on uneven ground, very painful. The gait disturbances that can result from this are very similar to ankle arthritis or midfoot arthritis, because they really just causes pain, and that results in a limp because you can't tolerate much in the way of changes to the ground. Causes, again, trauma, primary degeneration, or flat-footedness. Adult-acquired flat foot is going to strike these 3 joints. This is where when you see somebody with flat feet, their foot hits the ground and that arch kind of rolls inward. That's what's happening. That complex is giving way because of the ligaments, because of the tendons. The muscles are not doing what they're supposed to do to lock that in place while they're standing. So symptoms of arthritis, and I've touched on this as we've gone along. Pain, tenderness to palpation or pushing on it. The difference between pain and tenderness is one is caused on its own and the other is caused by somebody touching it. So if you see those 2 words used differently. Swelling, again, inflammation through the knee, inflammation through the ankle. My ankle gets all puffy by the end of the day. And you can actually have associated swelling of the soft tissues around the joint that's bothered as the body sends more blood down there in an effort to try to deal with the, kind of abnormality or the inflammation in an effort to heal it. Certainly loss of motion is a huge component of arthritis. Change in the joint alignment. And if you kind of go back to that x-ray that I pointed out of the ankle, I don't want to go all the way back, but that was very symmetrical arthritis. The joint had narrowed kind of just in its normal alignment. But sometimes Jeff and I will see patients come in, and instead of being bone on bone flush across the joint, it's bone on bone like this. And what can happen if the joint tries to shift one way or the other as the arthritis sets in, you can get erosion of one or both of the bones. And so that flat surface of the end of your shin bone where it meets your ankle bone becomes like this, and it makes things a little bit harder. So you don't want to kind of get to that level, but it certainly can happen. Everybody has seen somebody with knock knees or bow legs, right? That's a change in the joint alignments, mostly secondary to arthritis. Difficulty walking, obviously we talked about that already. Stairs is when you're talking about the ankle, and uneven ground is when you're talking about the subtalar joint. And long distances, you know, I can walk so far and I do okay, and then all of a sudden it starts to really pain me, and I have to sit for a while. And then when I get up, it's stiff again. You know, the symptoms are very, very common and very similar between joints. So how do you diagnose this? What goes on in the office? You know, what can you expect when you come into our office to be treated for your symptoms? Obviously, the symptoms are reviewed. The most important thing to Jeff and I, to anybody, you know, any clinician, should be your history. When do you get your pain? Where do you get your pain? How long have you had your pain? You know, how many years has it been present? Has it worsened? What do you do to treat it? Do anti-inflammatories work? The braces work? All of those things are very, very important to us. We're going to examine the legs, the ankles, and the feet. A lot of people who come into our office are always a little bit shocked when my medical assistant, who's not here today, says, take off both of your socks and shoes. Because the nice thing about being an extremity surgeon is I have a template to go against. You've got a normal, well, I mean, hopefully you've got a normal side, it's not bilateral, but you've got two sides to look at, so we always want to look at both sides. One of the most common things that we do in our office is, before you get seen, we get x-rays, and we get weight-bearing x-rays. If you've had weight-bearing x-rays within the last 2 months, we generally will forego getting those x-rays. A lot of people say, well, my primary care doctor ordered x-rays, and I pull them up online because we, you know, obviously have access to the hospital's x-ray system, and they're not weight-bearing. And so looking at a non-weight-bearing x-ray is synonymous in my mind to sending or bringing your car into the mechanic and saying, I'm going to keep the keys, I don't want you to run the engine, but I want you to fix it. Because you can't see what that joint looks like. The joint might look fine, but then when they stand on it, that joint space disappears altogether. So x-rays are always ordered. You know, even if it's a soft tissue, oh, I have a bump or a lump on my foot, we need to know, is there a calcification there? Is there, you know, a bone sticking up? We need to kind of look at the skeleton as well as the soft tissue. At that point, we would then say, oh, geez, you know, this is something that looks like it's a tendon. We're not seeing that on x-ray. We need to get an We need to get an MRI. If it's really bad arthritis and we're considering doing some sort of surgical intervention, we need to get a CAT scan, because that's like a high-powered x-ray. So it's going to show us exactly what the bone quality is, what the bone, you know, alignment is, and that's a much better study. But interestingly enough, a lot of patients will come into us with MRIs done already, because the primary care doctors really like to order those right away, but they don't have x-rays done. Again, an MRI, how are you positioned for that? Right? You're lying flat on your back, no weight on your limb, you know, it doesn't really belie or let us know what the alignment truly is, and you know how that could be bothering you. So treatment options for arthritis, okay? There's two very easy ways to look at this. You can change your life to fit your foot, or you can change your foot to fit your life. The first one is up to you guys. The second one involves me. I can give you advice on the first one. The second one is, you know, when we meet and I'm dressed in blue with a little hat on. So things like weight loss, right? We go back to one of the first slides that I showed, 3 to 4 times your body weight, you know, with nothing in your hands. If you're carrying something around, you know, a lot of people, they go on vacation. I think one of the young lady in the back said she's going to France for 2 weeks. She's been doing a lot of walking, right? All of a sudden, you go from doing very little walking to doing a lot of walking. One of the things I got used to seeing, you know, when I first moved down here was people, oh, I was up in Boston for the weekend, or I went to New York for the weekend, and we were shopping and walking all over. Well, we all know the streets in Boston. I mean, I think, what was it, one of the governors from the Midwest said it was because the Irish were drunk when they made the streets. But we all know the streets in Boston are, you know, cobbles and curbs and all, you know, and so, you know, people come back and they've stressed out their joints. Keeping that weight down takes off all of the, well, not all of, but a lot of that stress. I always tell my patients, I say, look, if you lose 1 pound up top, you can tell everybody you lost 3 to 4 pounds because that's what's off your ankle. You know, so it really makes a big difference. Nutritional supplements are becoming more and more popular, I guess, and maybe I'm just learning more about them. Things like glucosamine chondroitin, which I'm sure everybody has heard of at some point. It doesn't regrow cartilage. That was the original thought, was, oh, this is going to help to regrow cartilage. What it does is that it has a natural anti-inflammatory effect, as does turmeric, which I think is becoming more and more popular nowadays. There are other supplements out there that are good for joint health. I can't remember the other one. I'm trying to think of, not fish oil, but it's good for your blood, maybe fish oil. But anyway, there's a lot of them out there that they say help with joint health. Exercise, keeping yourself moving. Obviously, exercise flows into weight loss also. Diet, however, and if you're over, I would say even 40 years old, 35, 40 years old, diet becomes at least 50, if not 75% of what is going to maintain your weight. So there's been studies done on patients coming in and saying, Doc, I can't exercise because my ankle is killing me. Okay, let's fix your ankle. So the ankle gets fixed. They don't lose any weight because they don't change their diet. They keep their lifestyle the same even though their ankle has been fixed. And the chances of that fix wearing down and going back to where it was are much higher if the weight isn't maintained. Physical therapy is a very, very important part of treating arthritis, because if this joint is not kind of loading or mechanically aligned normally because of the strength, you may have one muscle on one side that's weak and a muscle on the other side of the joint that's strong. This goes for your knee or your ankle and foot. Then the joint is not going to load normally or evenly. And all it takes in the talus, in the ankle joint, is that talus to be 1 millimeter, just 1 millimeter out of alignment. Either it usually goes lateral because there's not a lot of medial, meaning inside, outside. It usually slides to the outside. If it goes just 1 millimeter, the weight-bearing surface that you normally put that 3 to 4 times your body weight across gets reduced by 50%. So if you think about, if I push against something with my hand like this, it may not hurt, but if I push against something with my fingers like that with the same exact force, that point loading is going to hurt because it's concentrated into a certain area. Cartilage breaks down. So that's why physical therapy becomes very important. Shoe wear is huge, all right, with the foot and ankle. It's absolutely huge. A lot of people come in and they say, oh my gosh, I went to Hanlon's, a very popular store, a great store, by the way, because it's one of those stores where they actually will sit down and fit you for shoes, as opposed to saying, here's a size 10 and a half, I'll be back in 15 minutes to take your money. They fit you, they make sure the width is normal. Gigi's up in Orleans is also a very good shoe store, and Marathon Sports. These are the places where I send most of my patients. I love New Balance shoes. I like Brooks. I love Keens as far as hiking boots and sandals go. There's also a company called Bionic, which is an online retailer. I think they advertise on QVC and places like that, designed by an orthopedic surgeon. They're not cheap. We're talking about, $85 to $130, sneakers or shoes. However, if you look at the number of steps you take and you divide that by that cost, it's not that expensive per step. So it is very important. Over-the-counter orthotics, we sell these through our office, but of course, you go into the supermarket or CVS and there's like 8 billion different kinds. I'm more than happy, as is Jeff. If you want to, come in, you can bring those kind of things in and we can tell you whether we think that they're strong enough for you. Sometimes people have to get custom-made orthotics, which are very, very helpful in stabilizing the shoe, or the foot rather. The stiffness of the shoe is incredibly important for midfoot arthritis. Every time we step, we kind of bend through that midfoot. If we have a shoe underneath us that you can't really bend, you try to bend it with your hands and you can't, or we've asked you to use an insert that you put in all of your shoes to make your shoe stiff, it's going to take stress off of those joints. And stiff shoes in general are very, I think anyway, they take stress off the foot if you're doing a lot of walking. These are Dansko clogs. They're very popular among healthcare workers and people who work on concrete floors. A lot of chefs also and kitchen workers will wear Dansko clogs. These tend to be a little bit difficult because they don't have a lot of stretch on top. If you have a bump on the top of your foot, they can cause a little bit of soreness there. Bracing is very important. We have a gentleman here who has spent his life making braces and orthotics and what we call Arizona braces, which is a custom brace made for your ankle. They can be bulky, they can be a little bit more inhibiting, but again, some people just don't want to go through surgery, and that's understandable. Surgery should be a last-ditch effort. And if you've exhausted everything else, or you feel as though the conservative measures have failed, then you can move on to that. Sorry. This is not a popular option. People don't like using canes. I understand that, but sometimes a walking stick, if you're going to be going long distances, can obviously help. This is what I was just about to get to. Anti-inflammatory medications, very good medications. There was all that news a few years back about Vioxx and Celebrex, about the dangers of heart disease and things like that. Certainly to be aware of. There's also a huge risk with anti-inflammatory medications of gastric issues, stomach issues, ulcerations, and things like that. But if you use them in a smart way, and you speak to your primary care doctor about them, and he or she knows that you're using those medications, they're going to be very helpful to you. I'm a big fan of Aleve because you take one after breakfast and one after dinner. It's an easy medication to remember to take, and it's over the counter, and you've always got something in your stomach to protect you. Icing, very, very helpful. If you think about it, arthritis is an inflammation, so you want to get rid of that inflammation. A lot of people also recommend a warm soap. This is important. It's big in the knees, and it's also, I've found to be helpful in the feet and ankles. So about 15 minutes before you go to bed, you put your foot into a bucket of warm water. You don't need to put anything in it. You can if you want to. And then, elevate for a little while and get into bed. It takes away that throbbing when you first get into bed, which can keep you awake at night. Cortisone injection or visco supplementation. That is a big fancy word for a synthetic version of the normal protein that lives in our joint fluid, which makes it kind of stringy, like hydraulic fluid. They found a way to kind of mass produce that, and we inject it into the ankle. It is not approved for the ankle by the FDA, and insurance companies won't cover it, but we do offer it because there have been a couple of smaller studies which show good effect from it. Cortisone works well for a little while, but usually is temporary. Lasts about 3 months the first time. Sometimes you get longer than that, but generally 3 to 6 months the first time. Second injection usually lasts about 2 months. Third injection lasts about a month, and then the fourth is kind of not helpful. But some people get a long-term relief out of it. So beyond all of those conservative measures, there are surgical measures that you can take. Sometimes if you find that your conservative measures have failed, you then, like I said before, change your foot to fit your life. These options in general include debridement, or removing debris from the joint, so-called cleaning it out. Not shown to be hugely successful in the knee. There was a number of surgeons in the late 80s and early 90s who would say, oh, we're going to scope your knee and clean out the arthritis. And they'd go in and do a little shaving, and 6 months later they'd say, well, that didn't work, you need a total knee replacement. And people kind of started saying, hey, you're double dipping here, and so they started looking at the success rates of this. However, in the ankle, it actually has been shown to work, and it's one of those things that I will do if the patient does not want to progress to the more aggressive treatments, which we'll talk about. Arthrodesis is a fancy word for fusing the joint. Fusion is a word that scares people. It scares patients because they feel like they're going to walk funny. They feel like they're going to walk differently. In the various joints I show you that I fuse for treatment for arthritis, 99% of the time people improve their gait because, and I don't mean to be flippant in saying this, but they're already walking funny. They're coming in with significant pain that's making them limp. That pain is gone because when you get rid of the joint, you get rid of the, when you get rid of the arthro or the joint, you get rid of the itis. So that inflammation that leads to pain and limping and progressive, disruption of the mechanical chain is gone. So the knee pain stops, and then the hip pain, can go away, and the back pain can go away because you're not walking like this anymore. You're walking on a painless, a little bit more stiff joint. A lot of the times it's not even more stiff because, the arthritis has created so much of a loss of motion. Arthroplasty is replacing or changing the joint, meaning you put something in the space of where the joint used to be, metal, plastic, soft tissue, in order to allow for continued motion but get rid of the pain-causing tissue. So debridement of the joints, this is a kind of a word that a lot of people mispronounce. It's chylectomy, which is used for hallux rigidus. And basically, if you follow these red lines, it's a removal of the bone spurs at the top of the joint. Sometimes there's something called a negative grind test, which is when you kind of grind one bone into the other on examination. If that doesn't produce pain, it indicates that the lower part of the joint is probably okay and covered with cartilage, and you can get away with debriding these bone spurs off the top to allow for increased motion. It doesn't get rid of the process which started the arthritis, but it gets rid of the tissues that are causing the pain, and obviously it gets rid of the bump on the top. What you see down here is the ankle and the subtalar joint. I rarely will do arthroscopy in the subtalar joint. I sometimes will do an open debridement, but that's pretty rare also because the statistics don't show that it's all that successful. With subtalar joints, you usually go from conservative measure to fusion or bracing. The ankle, however, if you have an area like this is essentially like a pothole in the cartilage. This is normal cartilage out here, and this is bare bone in here. This is obviously not normal, that's a metal spike. That metal spike is used to kind of poke holes into the bone to create some bleeding, which will lead to fibrocartilage formation, which acts like kind of a patch, almost like a pothole on the road. It's not normal cartilage, but sometimes it is enough to get people with early arthritis in a very focal area enough pain relief so they can function normally. Arthrodesis, or fusion. Again, I know that the word sounds dramatic and it sounds scary, but, and I think Jeff can back me up on this, the change that we see in patients and the number of times I've heard, Doctor, I can't thank you enough because it's been 20 years since I walked without pain, and they're walking without pain. So to me, it's a very successful option, and studies show that it is in fact a very successful option. So it's an operation intended to get the bones to grow together. You fool the body into thinking that there's been a fracture, almost like, let's say you break your forearm. Well, this is one bone and it broke and now it's got to be grown, it's got to grow together. We try to fool the body into thinking that same thing. All of the cartilage that's left on the joint, any soft tissue in between the two bones is removed, and then the joint is kind of scuffed up in order to get the body to have a healing reaction. For my ankle fusions, for my subtalar fusions, and for my midfoot fusions, I always borrow stem cells from the pelvis through a tiny little stab incision. I concentrate them down and I pack them into the ankle joint or the joint that's being fused. And the reason I do that is, we all hear stem cell therapy in the news nowadays. It's been shown that these cells will become osteoblasts when they're in the right environment, and those are bone building cells. So it's kind of a way of getting the most robust response, because you don't want to delay healing here. You want patients to get back on their feet quickly. Generally, it's 6 to 10 weeks of non-weight bearing, which it would be if you had a fracture. If I broke my wrist, I wouldn't be able to lift anything with my hand for 6 weeks until it healed. And so it's the same concept as that. Sometimes, if patients have medical problems, such as diabetes, a history of smoking, or even mild lung disease, will push that out a little farther to give the body more time to establish that solid connection. The only thing that's really not recommended with a fusion is high impact exercises. Most of my patients are not professional hurdlers. They're not high jumpers. They're not even intramural basketball players. But I have a number of patients who are pickleball players. I have a number of patients who and they do well with fusion because they can't play the way they are, and they want to do, they want it walking. I mean, the ability to walk after a fusion, even if it's your ankle, is completely normal. I mean, there's therapy that's necessary in order to get you to a kind of a training of your gait that'll bring you to that normal walking, but it's very, very successful. So these are some examples of fusion. This is an ankle fusion. I don't use screws that are quite this large. Those are pretty aggressive screws, but the ones you use are big because you want to make sure this is solid. The hardware generally stays in unless it causes a problem in the future. Once the bones grow together, the hardware is just kind of sitting there. It's not really doing anything. You can see, I'm going to point out here, this is the old ankle joint line. That's where the separation used to be, and now you've got bone growing straight across there. We put the hardware in, not necessarily to allow you to bear weight, but we put the hardware in to kind of squeeze the bones together because that's the way bone heals best, if it's got a lot of compression between the two surfaces. This is a subtalar joint fusion. This, a single screw put in from the heel bone and then one from the top of the foot. And you can see this is the area where the arthritis and the joint used to be, and it's all completely grown together now. This is a fusion for hallux rigidus. It's kind of a cruddy x-ray, I apologize. But you can see this area right in here, actually it's probably even a little bit lower, right in there where the screws are crossing is where the joint line used to be. And again, this isn't something that is commonly done by general orthopedic surgeons. This is something that's usually done by foot and ankle specialists, because when you're in the operating room, and Jeff has seen me kind of go through this, and you're making the decision as to where to put someone's toe or what position their ankle is going to be in, or their subtalar joint for the rest of their life, it's a big decision. And you want somebody who is comfortable making that decision based on their knowledge of the biomechanics of the foot and ankle. This is a midfoot fusion. So this is, again, the tarsal metatarsal joint, first, second, and third. When I was talking before about the uniqueness of this joint, it is very, very acceptable for function, walking, all of the above, to fuse the first, second, and third tarsal metatarsal joints. The joints out here are never fused because we need that motion. But there is treatment that you can do for those joints if there is pain out there. You basically remove part of the bone at the joint surface and pack in some soft tissue to allow for motion, but not leaving the bones to be kind of grinding into one another and thereby getting rid of the pain. A lot of people ask, why can't you do that over here? And the reason is it would make it too unstable. Your arch would collapse and your gait would be completely abnormal. So arthroplasty, or changing the joint, or replacing the joint. Hallux rigidus is the arthritis of the big toe. There are implants out there which are called hemi-implants, or half of an implant, which are very popular among the podiatric community, meaning the podiatrists like to put them in. Not a lot of people in the orthopedic world put those in because they have a relatively high rate of failure and continued pain. They're not really shown to be all that successful, and I don't do them. I would much rather do something like this, an interpositional arthroplasty, which is, again, where you remove some of the bone on one side of the joint, in other words, the bottom of the toe bone, and you put in some soft tissue to kind of create a bumper in between the two. That bumper can break down depending on your activity, but you do still kind of retain the option for fusion if you come to that at a later date. I do think that if that's where you get into surgical personalities. Are you a one and done type patient? Do you want one surgery and you never want to think about this again, or do you no, I want to avoid fusion at all costs. I'm willing to try this with the idea that I might need to have another surgery in the future. And that's one of the things we'll ask you about. I don't tell people they need surgery. It kind of drives some patients nuts, actually, because it's not up to me. It's up to you. It depends on your quality of life. It depends on the severity of your symptoms. I can recommend, I can educate you on what your options are, and the decision becomes yours. So, total ankle replacement, very, very, kind of exciting. A lot of people think this is relatively new technology, but they've actually been doing these since the mid-70s. Yep. However, back then, they were awful. The implants were terrible. They failed. They didn't do very well. The implants, I would say probably in the mid-90s to mid-2000s became so much better because they find the engineers finally realized that, well, geez, we shouldn't just be replacing this joint with a kind of a hinge, like a door. We need to replace the anatomy as it was, and that's what leads to the normal function. It used to be that, if you look at this image over here on the right, it used to be that the implants would require us to fuse together the tibia and the fibula, and then put the implant into both in order to get a bigger bone surface, and we've abandoned that altogether. This is what's called an in-bone. I don't do this type of implant because I find it a little bit aggressive up in the tibia, but they do make a smaller version of it now. And now they also make a version that is that allows for revisions of total ankles. I don't know if anybody in here has had to have a knee replaced more than once. It happens sometimes. You have to go through a revision. They pull the old one out and they put a newer one in. These are machines, and they can fail if they, if something happens, or God forbid, there's a fall and a fracture around it. Well, now we have revision stems. This is an implant that I used to use, and you can see it solely uses the tibia, which is this bone here, doesn't impact the fibula, and it recreates the normal kind of contour of the talus. This is a side view of the same implant. This is the implant that I use now. I've gone through, I'm on my third implant. I was trained on one. I moved to another because there was, they made custom implants for the patient, but the custom cutting guides were great, but the implant itself I didn't care for. It didn't seem to be as stable as the other ones. This is called the Scandinavian Total Ankle Replacement, or the STAR ankle replacement. It's been kind of heavily put in Europe since the mid-90s. It's got a 92% 12 years plus survival rate. It's got what's called a mobile bearing, which means that this plastic is on this groove on the talar component, but it is just sitting on this tibial component. So there's very little in the way of kind of rigidity of this. It allows for a more natural motion. The outcome studies, 20 plus year studies of ankle replacement versus ankle fusion, are very similar. So the question becomes, why do we do one versus the other? In younger patients, people who are under, certainly under 60 years old, I used to be 65, I'm kind of leaning a little bit more toward the mid, the lower 60s, 62, 63. Anybody who's younger than that has too long a duration of activity in their lifetime to risk going through a total ankle replacement, in my opinion. That is what's called a revision burden. It's the burden that you carry as a patient for the need for revising that total ankle. Anyone who's a laborer, lifting heavy loads, carpentry, up and down ladders, painters and things like that, they're not good candidates. Diabetes is an absolute contraindication. Smoking is an absolute contraindication. Lung disease, in my world, certainly that requiring oxygen is a contraindication because of healing of the soft tissues. People over 65, people with rheumatoid arthritis, people who walk for exercise, people who, even if they're still working desk jobs or office jobs and things like that, excellent candidates for total ankle replacement. It is a very good surgery. The one caveat to that is if patients come in that age group and they have very little motion to begin with, they're generally not going to get a lot of motion out of it. And so if you have less than, I would say 30 degrees arc range of motion of that ankle, I'm going to recommend a fusion as treatment for that. This is just a couple of shots they did when I did the first total ankle that Cape Cod Hospital ever had done, which was kind of cool to be involved with something like that. So these are just some shots. That's the component from the implant that I used to use. You can see when I wear a surgical cap, I actually look like I have hair. So adult acquired flat foot. We're kind of shifting gears here to flat footedness. It really comes down to a dysfunction of the posterior tibial tendon. That is a tendon which I'll show you on the next slide, wraps around the inside of the foot here, okay? And you can see this bow of the patient's foot out this way is not normal. We shouldn't see that. There should be an arch there that kind of rises up. It's one of the three arches of the foot. The other thing is when you look, the names for these findings in orthopedics are kind of funny because they're so simple. But if you look here, you can't see his toes, right? If you look over here, I can see 3 toes. Well, creatively enough, that's called the too many toes sign. Because the foot has collapsed this way, or the ankle and midfoot have collapsed this way, and the forefoot starts to veer out this way. The posterior tibial tendon is very important with maintaining the foot's arch. I always kind of compare it to Spider-Man's web because it comes down around the ankle and it shoots out into 9 different insertions underneath the foot. And so when it fires, it actually lifts up the arch, almost like a basket. The loss of the function of this tendon, even if it doesn't rupture, it can lose its function, and that leads to failure of the arch because the ligaments between those bones are not strong enough to maintain the arch on their own. Progressive flattening, very predictable pain pattern. There's pain along the tendon itself as well as pain on the outside of the foot here from impinging the tissue on the outside of the foot. And there's worsening stiffness and arthritis of the foot And again, I want you to kind of keep in the back of your mind that those 3 joints that I pointed out that make up the subtalar joint complex, those are the joints that become arthritic and very stiff very quickly. So this is the posterior tibialis tendon. You can see it coming right up here, right there. There's a bunch of tendons behind it. This tendon inserts, and main insertion is here in the navicular bone where it pulls up on the arch, but it goes underneath to insert across the metatarsals also. Once the posterior tibialis tendon has become dysfunctional, the foot will go into valgus, which is this alignment here. Valgus means that simply put, valgus means that your joint is moving toward the other joint. So knock knee is valgus knees, genu valgum is what we call that. This is a valgus hindfoot. It's not supposed to come this far out. You've got the too many toes sign here, and you've got the arch collapsed on the inside. Here's a great example of why we look at both feet when you come into the office, why we want you to stand. Some patients get annoyed that can you stand up, can you sit down, can you go up on one toe, they don't want to do exercises while they're in there. But you can see here this collapse, which is dynamic. If this person were sitting on the side of the bed, their arches could look completely symmetrical. If they had x-rays taken without weight bearing, their joints could look completely symmetrical. So the history becomes important, the examination becomes important. Treatment for this is based on the severity of the deformity as well as the symptoms. Sometimes it's simple pain at the tendon and the arch is not all that collapsed, it's just starting to. Sometimes the tendon can be cleaned up, but it generally doesn't heal very well on its own. Non-operative treatment, anti-inflammatory. Sometimes we can put you in a cast or a boot. I generally won't put you in a cast or a boot. Physical therapy is hugely important when the symptoms are mild. Orthotics are hugely important to maintain that arch. If there's nothing for the arch to fall into, there's no space there, it's going to take stress off that tendon. And oftentimes, even people with dynamic flat feet can have their pain cured with orthotic, either over-the-counter or custom orthotics. If it's severe and they're not a candidate for surgery or they just don't want to go through surgery, that's when we get into what's called Arizona bracing or AFO, ankle foot orthosis, which is a bigger brace that can maintain the position of the foot. It doesn't correct it, but it maintains it so to decrease the pain. Operative procedures are based on the status of the foot, meaning how bad is the forefoot, how bad is the midfoot, how bad is the hindfoot. Those things have to be addressed. It's kind of like an a la carte menu when you go to a restaurant. Well, I need to do this, this, and this in order to bring the foot back into alignment. Debridement, partial repair, again, not a hugely successful. It depends on the age of the patient and the MRI findings, which will often show an isolated tear. Tendon transfer and calcaneus osteotomy is a very popular surgery. If the foot is dynamic, if it can be swung back and forth, that's usually what I'll suggest. If it can't, we go for a triple fusion, which is a fusion of all 3 of those joints that we talked about before. Sometimes you have to do what's called a lateral column lengthening, which allows for the forefoot to be swung around so that you correct the too many toes sign. And sometimes you have to do a forefoot correction. It's pretty rare that you have to do that. One of the other things that's often required surgically when you do a triple fusion is an Achilles tendon lengthening, because as the heel bone goes outward, the Achilles tendon chronically shortens. So this is a tendon transfer. There's an incision made here. The heel bone is cut completely and slid over. I'm going to admit my failure here. This is actually a lateral slide. It's supposed to be going this way, but I couldn't find a good drawing of a medial slide. So generally, this part of the bone is brought this way, and screws are put across. The tendon transfer itself happens in here. The painful abnormal tendon is taken out, and one of those other tendons that ran behind it is put into its place. If you look at the alignment here, when we talk about triple fusion or lateral column lengthening, that's the alignment of the talus. It's generally supposed to be in perfect alignment with the first metatarsal. The lateral column lengthening, which is where you basically, almost like a jack under a porch that's tilted, you're jacking that foot over, the forefoot is coming this way, and that's going to help with the alignment of that. That's called Meary's angle. And that's what we're looking for in our x-rays. Here you can see a clinical picture. This bump right here is actually that person's talus. The head of the talus comes completely out from underneath the navicular bone, and it just basically pushes on the skin. That's one of the ones that I've seen in fellowship where you take the bandages off and you're looking at the head of the talus, and it's like, oh boy, now we got to go to the operating room. So this is the talar inclination, or the angle of the talus, and you can see that's, you know, if we were to look at this from the side, that pretty much matches up there. And this is called Kite's angle. This is the first metatarsal. So this is a very aggressive construct. I don't put this much hardware in. This is a stock picture, it's not mine. I generally use about 4 screws to do a triple arthrodesis. But you can see that in this situation, they have reestablished the pitch of the calcaneus. In other words, it's going from this to this. The talus is well supported on top of the calcaneus. It's hooked into the navicular bone, which is actually here, but via screws, and then you've got a calcaneo-cuboid joint fusion also. So shifting gears. And I know I'm going a little bit long, I apologize. I hope everybody's staying awake. It's warm in here, isn't it? So what is a bunion? Bunion is basically a misalignment of the big toe, but it really stems from a misalignment of the hallux valve, of the first metatarsal, the hallux metatarsal. Symptoms can be mild to severe. The deformity can be mild to severe, but it's not based on the deformity. We don't treat this for aesthetics. We treat it for pain. So there are some people out there, you know, there's a woman that goes to my church and she wears sandals every Sunday, and I look at her feet and I think to myself, how does she live with those, you know? But she's doing fine. They don't bother her. They don't hurt her. So you don't do anything about it. And again, this is called hallux valgus, so there's that word again because of the alignment of the joint. What causes bunions? Well, yeah. Needless to say, you know, narrow shoes, not a good idea. Tight-fitting shoes, high-heeled shoes, all of that puts stress on the forefoot because it really uses the toes to keep the foot in the shoe. And the more your toes are pinched together, the more it's going to angle your big toe inward and push your metatarsal outward, creating stress on the ligaments, which eventually give way. Inherited factors are definitely, I mean, you know, there's got to be someone in this room who says, I got my mom's bunions, you know, I got my mom's feet. It's there, but generally, even though you have the genetics for it, has to be a predisposing factor brought in shoe wear. Interestingly enough, side note, Japan, post-World War II, pre-World War II, they had very little in the way of incidence of bunions. So, you know, they just didn't have that problem too much. Post-World War II, after the American influence came in and high-heeled shoes and pumps and all that other stuff, the rate of bunions went through the roof. Because the genetics were there, but they didn't have the inciting factor to kind of bring them out. So symptoms, intermittent or chronic pain, usually it's intermittent, very limited footwear, the skin can break down. I've seen patients come in with severe bursitis, inflamed, even infected bursitis. It's often tender to the touch because of the bursitis and because of the strain on the ligaments on the inside of the foot. The x-rays are really what provides a clear view, again, weight-bearing x-rays, and also helps us with the diagnosis. So this is a pretty severe bunion, bilateral. This is called the hallux valgus angle. It's one of the things we use to decide what we will do. How are we going to treat this? Can a spacer be used, or does it need surgery? If it needs surgery, is it what we call a distal osteotomy, which is a bone cut down here, or is it a proximal one? This is called the intermetatarsal angle. The normal hallux valgus angle is less than 25 degrees. Less than 15 degrees rather. And the normal intermetatarsal angle is less than 9 degrees. So you can see this is pretty severe. As this bone heads, you know, kind of more and more toward the other foot, that's going to increase that angle. And this bone here, which has muscular attachments, is going to kind of go along for the ride. A lot of patients ask, what are these things here? These are called your sesamoid bones. They're normal bones that are supposed to live under the head of the metatarsal. They're supposed to live underneath this bone. As this bone moves into its abnormal position, the sesamoid bones kind of stay where they are, and so they actually will rotate around the bone. They'll rotate around the head of the bone, and that's one of the parts of correcting this. And it can lead to arthritis of those joints, which can become quite painful. So the treatment options for bunions, obviously there's always conservative management, good shoes, shoe wear modifications, wide toe box, tall toe box, okay? That's the two rally cries for shoes when it comes to bunions. Anti-inflammatories can work. Cold packs are actually very successful, but they're not going to obviously correct the deformity. They're treating the symptoms. This is a silicone sleeve used to kind of protect the toe or the bone from pressure from your shoes. And then this is a silicone toe spacer, which actually I use post-operatively in order to protect the correction that we do. Again, these things are temporizing. They're not going to realign it. They're just basically going to correct its alignment, somewhat, so you can, deal with the symptoms. If those conservative measures do not provide pain relief, again, that's what we're looking for here. Surgery is indicated. Surgery involves removing the unwanted bony growth and realigning the big toe. Now, there are people out there who feel very, very confident that just making a small incision here in their office and hacking off this piece of bone is going to give you a cure. However, it's not going to do anything for this joint other than remove half of it. And so there's really no chance for realigning the joint once that's done. There is a name for it. It's called a silver bunionectomy, but generally orthopedic surgeons don't do it. The realignment procedure involves adjusting the bone either here or here to take the entire joint surface and bring it back into a more normal alignment, and then use soft tissues to pull the toe outward this way. A mild deformity with a congruent joint, meaning the joint is able to be kind of rotated back into alignment, gets a distal bone cut or an adjustment near the joint. Moderate to severe, that gets a adjustment farther up the metatarsal, away from the joint. And then the severe deformity, which I know that one said 44 degrees, but I would absolutely recommend that patient gets a fusion, because the risk of recurrence it rises with the degree of severity of the bunion. So when you get into that range of even 40 to 50 degrees angulation, your risk of recurrence of that bunion without a fusion goes up, because you're relying on the soft tissue for realignment rather than the bone. When you rely on the bone, it's a little more predictable. So that gets an arthrodesis or a fusion. This is a chevron bunionectomy. This is a side view. You can see a 60-degree cut is made after a small piece of bone is taken off the side. And that actually allows us to move the metatarsal head back over. So you're actually kind of offsetting the metatarsal head from the rest of the bone, and a single screw is placed from about here across there to hold it in place while it heals. And then the overhanging bone is shaved down. And you can see how the joint here looks relatively flat. That's from shaving down that overhanging bone. But the majority of the joint is maintained. And actually, this x-ray is a little bit more than I would take off myself. Again, this is an x-ray I borrowed from my fellowship director. This is what's called a Ludloff bunionectomy. My fellowship director likes to call it a Ludloff-Meyerson bunionectomy because his name is Meyerson. He was the one that described it for use in the first metatarsal, as it used to be used in the fifth metatarsal only. And basically what you do is you make an oblique bone cut, and if this is the metatarsal kind of crooked this way, you rotate the metatarsal that way and cut off that extra bone there and reattach it. So on x-ray, it looks a little bit weird because the bone, you can see, takes on a little bit of a curvature, but it allows for realignment of that joint down there. And it allows for decompression of all of that bone that used to be pushing you on the shoes. So I'm going to kind of roll through plantar fasciitis relatively quickly. I do not do surgery for plantar fasciitis. The most important things to realize about plantar fasciitis is that the treatment is in your court. It is stretching, stretching, stretching. And it usually has a natural history of about 1 year. So it normally will just go away on its own even if you did nothing. The stretching will often decrease the time to about 6 months. So it's an inflammation. Again, we have the itis. It's an inflammation of the tissue on the bottom of the foot. It originates from the heel bone, and it inserts in the soft tissue out toward the toes. If it lasts more than 2 years, it's considered chronic, and some people will do adjustments to the Achilles tendon or the leg muscles in order to take stress off of that area. Risk factors, generally seen more in females, overweight patients, walking or standing on hard surfaces, walking or running on hard surfaces, tight calf muscles, which do have something to do with it, which is why we stretch back there, and either flat or overly high arches. Because again, if you think about that tripod, the plantar fascia is going from your heel bone out toward your toes. So if that arch is too high, the plantar fascia is going to be overly tight. If the arch is flattening, it's going to be overly stretched, and it can be kind of aggravated by the flattening process. There's the area where it typically hurts, right at the origin of the plantar fascia. Symptoms depend on the area of trauma. It can be at the origin, it can be at the mid-substance. It's very rarely out by the toes. 90% of it is at the heel bone. And it usually will bother people after exercise, but almost all the time, it's the first few steps in the morning. It feels like a knife stabbing in the bottom of my heel, and then it goes away. The reason it goes away is because you've torn the tissue again, and now it feels better. But tonight, it's going to tighten back up again, and you're in that cycle. So stretching is going to help to break that cycle, and that's why it's so important. You can use icing, you can use anti-inflammatories. Most studies show that it's not that successful. A night splint is very successful because when we sleep, our feet tend to droop like this, and that allows for tightening of those muscles. Keeping those muscles stretched out with a night splint, which I'll show you in a second, is very, very helpful. I don't do a lot of cortisone injections because it can risk weakening the tissue, and it can actually rupture and leave you with the risk of a flat foot. PRP is what's called platelet-rich plasma. I don't know if anyone's ever heard of that. It's blood we take from your arm. We concentrate it down to get things, a lot of what's called growth factors. Platelet-derived growth factor, endothelial growth factor, insulin-like growth factor, as well as fibrin, which is what kind of helps make scabs in our body. It's like that lattice of tissue. We inject that back into the plantar fascia to stimulate a healing response. You have to be non-weight bearing for 2 weeks, but for patients, I've actually signed up 2 patients this week for that alone because their symptoms have lasted more than 2 years, and that's a little abnormal. There was a study done at Cottage Hospital on Nantucket, and no one would ever think of that as a research center. But they have all the statisticians of MGH, so they did a really good study that was published in Foot and Ankle International that shows the success of PRP injections versus placebo or cortisone injections. However, insurance companies don't want nothing to do with it, so it's an out-of-pocket cost. Sorry. Casting and immobilization, sometimes used, but I rarely will come to that. So stretching exercises, this is just an image of some of the stretching exercises that need to be done every morning for 3 to 5 minutes in order to break that cycle of injury. And then we have calf stretching exercises. We have icing, which a lot of people do on a frozen water bottle because it lends massage at the same time. We have night splints, that's what you wear. The night splints that we use, however, do not have this giant thing in the back. They're more of a low-profile piece of plastic. Some of the ones we use are this size, but generally the ones we have are more low-profile. And then that's the PRP injection in the upper right-hand corner. But, again, the most important thing, stretching, because that's what will really make it go away if it lasts long. So when do you want to see a foot and ankle specialist? What would bring you to see somebody? Pain that lasts more than 72 hours, okay? Unless it's related to a trauma and you've gone to the ER, then we try to get you in as fast as we possibly can. Pain which increases with walking or exercise. That's an indication that something's wrong with either the way your joint is aligned or the joint itself. That's an issue. Sudden progression or by foot or ankle deformity. If you notice your arches just kind of, 1 month to the next, they're doing that. You gotta do something about it, primary care or a foot and ankle specialist. Any traumatic injury to the foot or ankle, again, toe fractures. Sometimes the primary care doctors get all freaked out about toe fractures. We generally don't treat them very aggressively. Buddy taping, maybe a protective shoe or something like that. We'd be glad to see you, but it's not going to be high priority versus like an ankle fracture or something like that. Chronic pain after a remote injury, in other words, I broke my ankle when I was 30, now it's starting to hurt again when I'm 60, that's an issue. And then flattening of the arch of one or both feet. And where to see a foot and ankle specialist? These are the 2 locations that Jeff and I, that's Jeff, that's me, and then that's Tori right there, and this is my medical assistant, Cynthia. These are the 2 locations we see patients. I'm in Sandwich on Mondays. I am in Hyannis one other day of the week, depending on my operative schedule. I operate Tuesday, Friday, Wednesday, Friday, Tuesday, Friday, Wednesday, Friday. And I always operate right now at Cape Cod Hospital. Thank you. So again, I have the nice thing about, I'm going to steal my priest's line. I'm never late because it only starts when I get there. So I have time for questions if anybody has any.